IFSO session. This is Dr. Wang Yang from China. I'm still the IFSO president, and I'm happy to moderate this session with our incoming president, Maurice, and also Shahar. So welcome everyone. And actually, this session, the main goal for this session is to try to encourage more young colleagues to do more research, because we need data, and data is the king. And we should not only focus on our clinical practice, but also share our experience using data to our colleagues around the world. So let's enjoy this session. Yeah.
Thank you, Wa. You are having immediately the first talk. So you will speak about your you have one? Yeah. And thank you for your first talk, Young Researchers in Obesity Healthcare Professional Call for Global Collaboration.
Okay. Thank you. And I'm going to give you a very short, brief opening to share with you what personally I have done in my country. And after my short presentation, I hope in the future we can collaborate in some research. So I'm from South China, in the city Guangzhou, in the first athletic hospital of Jinan University. And we also have many affiliation society in China or in globally. For example, Young IFSO, the big IFSO, and other local organizations as well. And our center also hosting our national database for metabolic and bariatric surgery in China. So last year, Young IFSO celebrating the 10th anniversary, and we, the EB, the members in EB published a paper in obesity surgery, and we list many things that we are going to do. If you are interested, you can download the paper, and we can have some plans in the near future. And for this session, actually, at the very beginning, I invited Chiton from United Kingdom, but unfortunately, he's not able to join us here. But maybe in the future, we can also invite him to share his tips. As you know, Chiton is one of the best researchers in the world in this field. And we also have accepted several very outstanding abstracts from all the submissions. So you are here, and we will listen to their study. And you can extend your presentation a little bit, because we have plenty of time. I will save the time for you too. So from the global registry report by the IFSO, our country, China, we're number 4 in terms of number of surgery, just after United States, Brazil, France, and China is number 4 now. And our national database last year, this is the very brief report. We covered almost all the provinces, all the area in mainland China. It includes 173 cities, and we have more than 214 hospitals performing bariatric surgery. You can see from this graph, for example, around 15 years ago, we only have a few hundred cases, and it increased a lot even during the pandemic. Last year, we have over 37,000 cases performed in our country. So you can see that sleeve gastrectomy dominate other procedures like other country, and the second is the wound gastric bypass. So based on this huge data, our team, only our center, in the past 3 years, we published more than 115 paper, which is PubMed Index paper, and the highest one is published in the Lancet, I think. Yeah. In other very good journal like New England Journal of Medicine, Lancet, and other Nature, Communications, JAMA Surgery, etc. I hope in the future maybe we can do some multinational or multi-center study together. So we are aiming at a very high impact factor journal to share our data and to our audience as well. So this is my personal experience. You know, you can see from this PubMed data. In the past, I'm quite lazy. We seldom do research, but recent year we try and very hard. Just this year, in the first up to August, we already have 45 papers published from our team. So you can see from the Google Scholar, the number of citations also increased. So that's our impact. When we publish paper, we hope our papers can be cited by other colleagues from the world. So in the past years, we try very hard on this as well. So we can see some good results here. So also based on in the Google Scholar, the number of citations in metabolic and bariatric surgery using this keyword or this label, I went number 9 in the world. So this is also very promising. And so this encouraged me or our team to keep going on doing clinical research. So in our country, we have the first and the only one Chinese journal for obesity and metabolic surgery. So our boss, Professor C.C. Wang, who is the editor-in-chief, I'm the director of the editorial board. It's a Chinese journal, but the abstract is in English. So we also actually have invited several past presidents from IFSO to send us some papers. We can translate it into Chinese, so our colleagues can also read your data as well. Another journal you are very familiar with, it is the official journal of IFSO. Yeah, some of us are also the editor or as associate editor as well. So we can read more from this journal and submit our paper to this journal as well. And recently, we have, in our country, we have some new journals related to, for example, this one, metabolism and target organ damage. It is also related to anything about bariatric surgery or obesity or any other metabolic diseases. So recently, this journal is indexed by the ESCI Scopus as well. Hopefully, we can receive the first impact factor next year, yeah, maybe more than 3.0, something, yeah. So this is a website. If you are interested, you can submit your paper to this journal. And recently, they invited me to be the guest editor for this special issue, Clinical Advance in Bariatric Surgery. You can also submit your data to this special issue. And last but not least, recently I start a small research group called Global Obesity Collaborative. So if you are interested, I hope I can collaborate with you and your team to publish our data together and to make some contribution to this field. So this is my email and this is the website. Let's keep in touch even after the Congress. So this is all my brief presentation. I hope you enjoy the following presentation as well. Thank you.
Thank you, Wa, for your great success. Any questions to Wa about collaboration?
Yeah, we can leave the question to the other presenter, maybe.
We have a few ideas.
Yeah.
So thank you all for your introducing yourself and your activity and your achievement. Congratulations. And would you please explain how the researcher, young researcher, can register their research and collaborate with your global collaboration?
Yeah.
For example, if they have an idea, how we can help?
Yeah, the simple answer is that you just need to email to each other and to show your interest in some topics, and we can organize, for example, the online meeting to share how we can start with. Usually in the past, we will start with some review or meta-analysis. This is very easy to do so. And the second step, maybe we can collect some clinical data, especially the multinational data or multi-center data. But of course, we have to get the IRB approval before that from each hospital. And with this document ready, we can start collecting data, not only for the prospective study, also prospective study is also okay. And we can also make some, for example, in the past we do some global survey. This is also a very easy way to start with. But of course, the clinical data is the best. And if we got some funding, or if your hospital got money, they can support further study, for example, the RCT study, then we can also do that. And yeah, but the very first is to collaborate and don't do anything just on your own or on our own. Yeah, because work as a team, especially the global team, we can increase our efficiency. Like in my experience I just showed you in the past, we only got several papers published per year, but now just using 7 months, we got more than 45 papers published already. So I think collaboration is the power. And yeah, please email me if you are interested in any of these. Yeah, I'm happy to discuss.
Thank you so much. So, any question, comment? Unfortunately, don't have Chiton here, so we jump to next speaker. I would invite to Jiong Dang, Dr. Jiong Dang from China, to talk about new anti-obesity medication. Yes.
Okay, thank you for introduce. I'm Dr. Zhiyang Dong. I'll talk about the new anti-obesity medication versus surgery for recurrent weight gain after metabolic bariatric surgery. So I think it's a quite hot topic. I can see several long about topic GLP-1 and surgery. What happened? Stop? Okay. Okay, I have no COA to report. So first is a little bit background. What is weight regain? It's be defined as progressive weight gain that occurs after achievement of an initial success weight loss. As EWO is more than 50%. As we can see, this topic is popular. We can find from the PubMed is about 1,600 publications about this topic, GLP-1 with GLP-1. And first we should know some rate about regain, like in AGB, 38% regain out of 1 year. And in sleep, about 28% after long-term follow-up, about 7 years as a report. And in gait bypass is about 4%. At the long-term follow-up is about 3 to 7 years. So as we all know that they have a lot of risk factors for weight regain after weight loss surgery, like anatomic and surgical factors, and endocrine and metabolic factors, and the lifestyle, eating patterns, and the physical activity, and the physiology factor, and mental health. But what should we do after weight regain after weight loss surgery? Now, Dr. Melina gave us a good answer and a nice paper and a summary every approach about weight regain after surgery, like MDT approach for weight regain after surgeries. So in his paper, there are several key points like behavioral intervention and the medication like GLP-1 and the endoscopic approach. The last one is revisional bariatric surgery. So today we're going to focus medication like GLP-1 is better or reservation bariatric surgery is better for weight regain out weight loss out surgery. So what which one we're going to choose? As we all know, GLP-1 have a several effect like enhance insulin secretion and inhibit glucagon secretion and delay gastric emptying and reduce appetite. And as we all know, this paper published in New England Journals, 1 weekly GLP-1 in adult with overweight and obesity. And they also show us a good result after 1.3 years, about 12% weight loss. So some doctors support anti-obesity medication like GLP-1. They consider for using GLP-1 to treatment weight regain after surgery. Like first one, sustainable weight loss. So they also have a lot of publication to support this view. And the second is supplementing surgical weight loss effect plus improving type 2 diabetes. They also have some evidence, so I'm not going to report the detail. The third one is probably improving IHI levels in OSAS patients. They also have several RCT and clinical trial to support this view. And the fourth is improving metabolic status. And the fifth one is cardiovascular protection. So that's why this doctor support anti-obesity medication for weight regain after surgery. And another doctor is not considering use GLP-1 in patients with weight regain after surgery because they have two reasons. The first reason is patient tolerance and adherence to medication. Like more and more applications report the complication after the GLP-1. And the second one, like before, they have some medication. There was dyspnea in the history. So we can go back in the history. No one medication survives. Another opinion about using like reservation surgery in patients with weight regain after surgery. They have some opinion about additional weight loss. We can see several papers, several clinical trials about sleeve and sleeve to RYGB and sleeve to BPDDS and RYGB to gastric pouch bending and RYGB to long pouch gastric bypass and RYGB to distal RYGB and RYGB to BPDDS. So they all show us they have a good result, about more than 50% EWL result. So the second one, we also can eliminate the complication for primary procedure. So, and also have some doctor not support using reservation in patients with weight regain. Why? The first one is more technical challenge for surgeons because the second surgery or revisional surgery is difficult for some patients. And we never know what happened during the surgery. The second one is longer operation time may cause a lot of complications. So what should we do? How to choose according what I talk about? In my opinion, we have a several factors must be taken into account. The first is cost of weight regain is important. Some may be because technique and or anatomy. The second one, patient's overall health. The third one is type of initial surgery. And the fourth one is patient's preference and compliance. The fifth one is long-term outcome. And the last one also we should consider about cost and the risk. So let's do some summary. Both obesity medications and the surgical approach have a low in managing recurrent weight gain after metabolic surgery. So the choice of treatment should be tolerant to the individual patient's need, considering the underlying cause of weight regain is important, and the potential benefit and risk associated with each patient. So that's all. Thank you.
Thank you very much for this great overview. I think we should really stick to the term recurrent weight gain instead of weight regain. I think the new terminology is very important also.
Thank you.
But another question is, what kind of examination do you do before you decide if you go for medications or for additional weight loss surgery?
So as I say, it's important. We should consider a lot of factors. But like Dr. Maria reported some protocol in his paper, it gave us a good answer. The first is MDT, which discuss an assessment first, and to decide which one is better for this each patient.
So do you do some examinations like the gastroscopy before or a CT scan or to
Yes.
to
Evaluate
consider
the pouch.
the pouch evaluation?
Right.
You're doing that also.
Yeah.
Any questions from the floor? Okay, thank you for your presentation.
Okay,
and
thank you.
We'll go to the next speaker. The first abstract is about plant-based caloric restriction diet on weight loss obesity, and it's from Kellingbur Mutailipu. Is he here? Actually, we know that it's uploaded. But then we will jump to the second and we will come to the first abstract later. Yuki O is here? Perfect. So the efficiency of tirzepatide on patients with type 2 diabetes and chronic kidney disease, a perspective of a two-arm observational study.
So young surgeon work on hot topics, anti-obesity medication.
Is it? Okay. Hello everyone. I'm Yukio from Japan. I'm really appreciated to accept my theme in this great session. Today I would like to show you the efficacy of tirzepatide. Maybe a lot of surgeons are interested in the new drug and a patient with type diabetes and CKD in observational study. This is my disclosure. The tirzepatide, the world's first GLP-1 and GIP receptor agonist, has demonstrated overwhelming efficacy of weight loss and glycemic control for people living with obesity and type 2 diabetes. And the average TWL is 8 to 11 percentage. And however, the efficacy and the safety in these people complicated CKD has not been investigated. So we conducted the present study on Japanese subject with TCD and CKD to evaluate the efficacy and safety of tirzepatide switching from conventional GLP-1 receptor agonist. This is a method study design. The key inclusion criteria are shown as follows. CKD and over 7% of HbA1c, and receiving duraglutide for at least 3 months as pre-treatment. We got a consent from the subject and allocated those who switched to tirzepatide and those continued duraglutide. And the primary outcome was the difference of changes in HbA1c after 24 weeks between the groups. And the secondary outcome were shown as follows. So sorry for the busy slide. I pick up the same key point, and we had excluded the subject on response in stimulating agent or HPH inhibitor and on diuresis. And we got a sample size by calculating the results of phase 3 trial for Japanese, and finally we assured the 22 cases per groups were needed. And this is a flow chart diagram of the study, and finally we got 23 subjects in tirzepatide group and 25 subjects in duraglutide groups. So let me show you the results. First, baseline characteristics, and average age was around 70 years old, and BMI was 26 to 27. It means the obesity from Japanese criteria. And HbA1c, regarding HbA1c, is in tirzepatide group, it was slightly higher than duraglutide group, but there was no significant difference. And for CKD classification, mainly the cohort was the D3B in international criteria. And the concomitant anti-diabetic agent, the slightly higher rate in duraglutide group of insulin users, but there's no significant difference. And the proportion of the CKD classification as shown as follows. So this is a result primary outcome. Tirzepatide significantly reduced HbA1c and body weight. And of course, tirzepatide had reduced fasting plasma glucose and visceral fat areas. And while in duraglutide group, renal function had decreased over 6 months, finally we got a significant difference between both groups in UACR. So it meant it could be prevented by tirzepatide for progression of nephropathy. So to predict the efficacy of tirzepatide, we conducted the regression analysis in tirzepatide group between baseline parameters and the change of HbA1c. The significant variables were, for example, the diabetes duration, HbA1c, and sometimes the visceral fat area. So we lost the minus on HbA1c, but in multiple regression analysis, we got the 2 items had detected for the significant variables. So it can be the possible factor for this to do with visceral fat accumulation. And so since we had a slightly difference between both groups in baseline HbA1c, so we adjusted by uncover the result, but the result was same then, significantly. So let's get to the discussion. So the function of white tissue is to regulate circulating lipid by the release and storage of the fat-free acid. And the infusion of ZIP might be able to restore the original fat buffering capacity by correcting wide tissue blood flow. In clinical trials, but although this is the result from between the tirzepatide and insulin glargine, tirzepatide reduced the trend of UACR and finally got decline of the EGF suppression, decline of the EGFR. So, but no GIP receptor and express indicator is suggesting it's in an indirect mechanism. So decreasing USCL may require more long-term observation in our study, but it gotta be a positive result in the future. I expect that. So as a limitation, this is not an RCT cell selection bias may be introduced, and but only a small sample size, and participants were exclusively Japanese, so which represents the general liberty of the findings. This is conclusion. Thank you.
Thank you, Yuki. Nice speech. I have a question. Would you please explain about your complication between two groups? For example, nausea, vomiting, diarrhea, hypoglycemia, pancreatitis.
Thank you for the question, and I'm sorry about we didn't show about safety in this slide because I hadn't had time, and so yeah, the complications in tirzepatide group, of course, mainly gastroenterological symptoms is mainly maybe about 30 to 40% of subject, and in two subjects we got hypoglycemic symptoms who had insulin concomitantly. So we had to pay attention to use the drug for this patient using the insulin.
And what about your inclusion criteria for BMI? Any cutoff for the BMI for inclusion in your study?
In this study, we didn't set the BMI for inclusion criteria because the subject of this study is not for treating the obesity, just for the HbA1c. So we didn't set the BMI.
One more question from my side. Now the study is finished, right? What do the patients do now? Do they continue with the medication, or do they stop now at the end of the study, or what do they do?
Oh, thank you. Almost patients are continuing the medication until the tirzepatide group, but some, maybe one or two patients discontinued the tirzepatide because of the HbA1c has excessively decreased for our expectations, so below the 6.0%. So they opt to they discontinued treatment for the diabetes. But yeah, it's just a rare case, so it's not going to be not universal. And some subject from the duraglutide group start the tirzepatide cause the deteriorated of the HbA1c.
Okay. Any other questions?
How about the first speaker, Jun Wei Guo? Here, Dr. Guo. Okay, not here. May go to the next one.
So go for next presentation. I would invite.
Okay, so the speaker of our first abstract is here. You can come immediately. It's Dr. Yun-Wai Go, and we will speak about plant-based caloric restriction diets on weight loss in obesity.
Okay. Supposed plant-based. Oh.
Yes, this one.
Oh.
Good morning, all experts. It is an honor to attend this meeting. I am Guo Junwei speaking on behalf of my colleague, Calabinura Mutilip. The topic I'm reporting is plant-based character reduction diets on obesity management. This study aimed to compare this study aimed to assess the impact of plant-based character reduction diets compared to the traditional character reduction diets on obesity management. The study was a 12-week single-center, open-label, and randomization controlled trial. This was our inclusion and exclusion criteria. Patients were equally randomized into two groups, the plant-based character reduction diets group and the traditional character reduction group. Both groups were advised to follow a daily character diets for 1,600 kcal for men and 1,300 kcal for women. The PBCRD group had a plant-based diet 5 days a week with unrestricted food choices, but limited character reduction diets on the remaining 2 days. The CRD group had limited character diets with unrestricted food choices throughout the week. The primary endpoint of the study was the change in the weight after 12 weeks. Second endpoint included the following. In these studies, the statistical methods adhered to the principles of randomization, allocation, concealment, and blending. At baseline, the patients in the two groups were well balanced, ensuring data comparability. The difference between the two groups was not statistically significant. Total body fat was markedly reduced in the PBCRD group with statistical significance. There was a trend towards a reduction in visceral fat in the PBCRD group. Uric acid levels reduced and the urea nitrogen levels increased in the PBCRD group with statistical significance. The 3-hour blood glucose levels were lower in the PBCRD group with statistical significance. Other glucose parameters remained unchanged. Liver enzyme levels and CP values were lower in the PBCRD group with statistical significance. SOD was lower in the PBCRD group with statistical significance compared to the CRD group. In conclusion, the two groups reduced weight, altered fat distribution, and improved hepatic steatosis. The PBCRD group had additional effects on total body fat, uric acid, and oxidative stress. Special thanks to the Department of Endocrinology and Metabolism at Shanghai 10th People's Hospital, Tongji University. We have no potential conflict of interest to report. Finally, I would like to thank you for your attention and for the opportunity to share my colleague work at this esteemed conference. Thank you.
Thank you very much.
Thank you.
Wait, we will have some questions, right? Can we ask you some questions?
Sorry, I am only speaking on behalf of my colleague. I'm not involved in this study.
Okay.
Sorry.
But maybe you have some background information about what we can ask about the study. So, for example, I saw that they had the same calorie intake, both groups of 1,600, which was right. So, how have you controlled that? Do they have standardized meals, or do they just count it themselves, or how do you know that they are exactly had this intake of calories that you're reported?
The PDCRT group had a limited character, had plant-based restriction diets on the 5 days a week, and with unrestricted food choices, but limited character diets on the remaining 2 days.
And do these plant-based eaters, they were plant-based eaters before already also, or do they just do this for this 12 weeks for the study reasons?
Yes.
Only for the study, but normally they eat meat?
Yes. Yes.
Oh.
Yes.
Okay.
Thank you. Last one.
Okay, thank you. And lastly, may I invite the last speaker, Dr. Siqi Wang from China, to present on the topic study on the role of gastric-derived GLP-1 deficiency in obesity-induced appetite dysregulations. And after the presentation, may I invite all of us in this room to take a good photo before we are leaving. Okay, thank you. Dr. Wang, please.
Okay. Thanks for your introduction. Hi everyone, my name is Wang Siqi and I come from China-Japan Friendship Hospital. I will be discuss our research on the role of gastric-derived GLP-1 deficiency in obesity-induced appetite dysregulation. I will share our research from the following parts. Firstly, obesity is a significant public health challenge, leading to various leading to various chronic diseases that affect millions globally. Recent study have identified GLP-1, a hormone traditionally associated with intestine, as being present in the stomach as well. After intragastric glucagon injection, GLP-1 can be detected in the gastric vein, rapidly reaching the portal vein. This suggests that gastric GLP-1 may have a swift impact on metabolic regulation. But the role of gastric-derived GLP-1 in appetite regulation is unknown. Some research have found that knockout of the intestinal GLP-1 does not impact appetite, and the GLP-1 is easily degraded by the DPP-4 with an average half-life only 2 minutes. So we hypothesize that gastric-derived GLP-1 may be related to appetite regulation. So our research seek to explore whether gastric-derived GLP-1 is involved in the modulation of appetite and to determine its potential role in weight reduction. We conducted our study by grouping patients scheduled from metabolic bariatric surgery and assign their appetite using tools like adult eating behavior questionnaire and daily caloric intake measurement. Additionally, we quantified the GLP-1 positive cells in surgically removed gastric tissue sample through IHC and evaluate the correlation between GLP-1 expression and appetite in patients. To further explore the relationship between gastric GLP-1 and appetite, we established GLP-1 knockdown animal model and examine the changes in feeding behavior and the expression of appetite-related factor in the hypothalamus, such as CART, PONC, and NIPI grip. About the results, firstly, our finding revealed a significant difference in the number of GLP-1 positive cells in the gastric mucosa among patients with different body weight. Also, we observed a negative correlation between GLP-1 levels and body weight. AEBQ results shows that severe obesity was associated with increased food approaching behavior and a decrease in food avoidance, leading to a high average daily calorie intake. In our experiment model, we have demonstrated the successful establishment of the GLP-1 low expression model and found that reduced GLP-1 expression lead to increased food intake and faster gastric emptying. Furthermore, there are an increase in the expression of CART in the hypothalamus, supporting our hypothesis that GLP-1 deficiency might contribute to the dysregulated appetite in obesity. In conclusion, our study suggested that a reduction in gastric-derived GLP-1 in the obese state is potentially associated with increased appetite. This finding highlights the potential of gastric-derived GLP-1 may be a new target for the treating obesity. Finally, thanks for my tea and thanks for your attention. Thank you.
Thank you, Dr. Wang, for your great work. So any questions from the audience or from the moderators?
Yes,
Thank you.
please.
There's a microphone at both sides, on your right. Yeah.
I'm Thanasis Pantelis from Greece. Congratulations for your work. I would like to ask this. People who take GLP-1 agonists usually consistently say that they don't have this food noise. Do you believe that this could be an answer or partially an answer to this issue? I mean, the currently available GLP-1 agonists could somehow potentiate the action of the gastric GLP-1? Thank you.
Sorry.
Would you rephrase your question in a simple question?
So, in this study, you focus on the gastric-derived GLP-1, right?
Yeah.
So people who already take GLP-1 agonists right now, the currently available medications, one consistent finding is that they say that they don't have this food noise. They don't constantly crave for food. And this is something that has not been, cannot be explained because it cannot be measured so far. So according to your opinion, do you believe that your findings could be an answer to this mechanism?
Yeah, I think we need more experiment to evidence this. We need maybe more work to evidence this. But this is
the question is not only for you, it's because there's no evidence, it's for everybody. Do you believe that this could be an answer to this?
Any comments from the audience for that question?
I think it's a difficult question to answer because GLP-1 agonists or GLP-1 receptors are in the brain, throughout the gut, stomach. So you kind of have to separate the measurements. I suspect the food noise that patients get or the benefits from that is related to the receptors in the central organs.
Thank you.
Okay, thank you. Any more questions? If no, thank you, Dr. Wang. Very well done. And so, thanks everyone for coming here. And I hope you enjoy your stay here in Melbourne and continue to do research and collaboration together. So, any other things?